It's ready. Fine. So we'll make a start. Thank you for those who've joined us, and thank you for those who are going to review this at their kind of comfortable time. This is the second talk in the Safe by the Probe series, and I feel kind of one of the most important skills and most widely used procedures in the ED, and you basically get the most out of this procedure. And very important to have this skill anywhere you work in the hospital, actually. And today we have Dr. Salman Naeem. He's a consultant in emergency medicine at William Harvey. And he's going to be talking about ultrasound-guided IV cannulations and some tricks and tips, and might also discuss about a new project that he's going to be involved in. Apart from being a consultant, obviously he's a POCUS expert. He holds a PG cert in medical ultrasound from Teesside. But having known him for the last few years, somewhat worked from him, learned from him, he's an amazing educator and a big advocate for the use of POCUS in ED. And that's where our wavelengths meet, I think. So thanks for agreeing to do this, and I'll let you take it away.
Thanks, Otto. Thanks for a very generous introduction. Good evening, guys. Thank you for listening to me. I'm just going to talk about today about ultrasound-guided IV access. And as Gokul said, it is one of the most common procedures that we do with ultrasound. However, it's not without its issues and without its expertise. So you need to be an expert, I would say, to be doing ultrasound-guided IV access. I remember when I was taught about it, I was taught the wrong way, and I gradually, with time, I learned how to do it properly, and now I've got a good success rate with it. So let's go talk about some basics, some physics, some basics of ultrasound, and about ergonomics and how to get a good success rate with your ultrasound-guided IV access. So let's hope it works. There we go. So yeah, this is a controversial statement. Being a POCUS enthusiast, but I would say the best cannula is the one that you don't have to use an ultrasound for, because the good thing is that it's superficial, and most of the cannula length is within the vein, and that's where it matters. The longevity of the cannula matters, and the length of the vein, cannula that's in the vein, is related to the longevity of the cannula. But also because you will know where you're going, it's superficial, you can see the vein, and it's without lots of hazards. When we use ultrasound, there can be a lot of problems that we can encounter. So let's talk about it. There we go. So why bother? So yeah, ultrasound, I think ever since I've started using ultrasound, I have not put in a center line just because we couldn't get IV access. And I remember, quite old now, but I remember the times when we used to put in center lines just because we couldn't get peripheral IV access. So it's quite good for people who are obese, people who've got cancer where all of their veins have been used and are thrombosed, or people who are IBD who put in medications through the cannulas and drugs as well. So I think in the last 6-7 years, I have not put a central line just because I couldn't get an IV access. So one of the big things about any procedure is about preparation. We need to prepare our patients, we need to prepare ourselves, and we need to prepare our equipment. So if you don't prepare, the chances of failure are quite high. And this is where probably most of us, when we learn ultrasound-guided IV access, fail. I don't have a good success rate just because we don't prepare. And we're going to talk about a few steps about preparation, how to prepare yourself, your patient, and your equipment. So yeah, talking about, you have to prepare the machine. So you need to make sure that you got the right probe, you've got the machine on charge, you're putting the patient details in the machine, and it's in the right place. So it should be opposite to the arm that you're cannulating. So suppose if you're cannulating the right arm, it should be on patient's left side in your line of sight. Again, we're talking about equipment, so we need to make sure that we've got all the necessary equipment. We also need to make sure that we've got something to cover the probe with, clean, sterile jelly, and also something to wipe the jelly afterwards as well. Because most of the times what happens is that we put it in the probe, so we put in the cannula, and when we try to stick the tegaderm on the cannula, it doesn't stick. And if you don't clean it very well, it won't stick, and the chances of the cannula coming out are quite high. And one of the things that we kind of forget, or we're in habit of saying sharp scratch when we put in the cannula, and we put in the cannula. It is slightly more painful than a sharp scratch, especially if you're going and digging in deeper as well. So you have to prepare the patient, say, look, it's going to hurt. Please try to stay calm. Keep your arm as immobile as possible, because this is where the success rate lies. I've cannulated children who are moving their or rotating their arm. All of their arm is in the same position because people are holding it down. But even if you're rotating it, all of your veins and your muscles are moving. So it's quite important to really consent your patient and let them know what they're going to expect. Also, if you're passing through fascias or muscle, it might hurt a little bit more as compared to a superficial cannula. So it's all about making sure you get all of these things right to have a good, high success rate. So as I said, these are the equipment. So I'm just going to talk briefly about ultrasound probe covers. In my practice, I use a tegaderm, and I think it's a good enough probe cover. But with the caveat that I make sure that I clean the probe with a Clinell wipe or any antiseptic solution, and you make sure that you've got the right cannula as well. So talking about small cannulas and large cannulas, we're going to talk about the length and how it matches with ultrasound-guided IVXs. So again, probe, we need to have the right probe, which is going to be the linear high-frequency probe. Linear probe is used for superficial tissues, and the good thing about the linear probe is quite high resolution. So even a small needle would still be visible with the linear probe. If you're using a curvilinear probe, then I think it might not be the right probe for peripheral IVXs. Maybe you can use it for central one because you've got a thicker needle, but not for peripheral IVXs. So as we talked about consenting your patient, making sure you got the patient in the right position. So we're going to talk about a little bit about ergonomics as well. And we're going to talk first about anatomy. So remembering your veins and remembering which veins you can cannulate. So this is a picture of the arm. And what I would suggest that if you're using ultrasound, try to move away from the joint spaces. So anterior cubital fossa or the wrist joint, just move away from them. Try to put a cannula in a flatter surface, which is the forearm or maybe the arm itself. So what are the veins we can use? Guys, just to confirm, can you see the mouse pointer?
Yes. Yeah, you can see the mouse.
Okay, great. So on the arm, on the hand, we don't need to use an ultrasound unless you've got a patient who's got lots of fatty tissue. So usually for the hand, you can use it without ultrasound. So it's quite superficial. So if the vein is quite superficial, ultrasound might not be the way to go for it. What you need to do is you need to put a cannula within the forearm, and we've got plenty of veins on the supine plane of the forearm. And then we've got basilic vein as well, which is a little bit deep, but it's a very good vein if you are not having success in the forearm. And sometimes the cephalic vein as well, especially when you go up into the shoulder as well, it becomes a bit more superficial. But these are all the veins that you can see on the supine plane of the forearm. But if you turn the hand, if you turn our forearm, you can have quite a lot of veins on the hairy surface of the forearm as well, which I call. It might be difficult to stick the tegaderm, but if you are struggling, remember to check the veins over here as well. And there are quite a few times that I've cannulated people on the dorsal surface, just because you got lots of good veins over there and you can easily cannulate them. Okay, so let's talk about ergonomics, which is quite important. I would say the most important bit if you're cannulating somebody. So ergonomics is about your position, your patient's position, and how you're going to hold the probe as well. So this is a picture that I've taken always slightly wrong, because I am cannulating the person's right arm and the machine is on the right side. But this is what happens in ED. We don't have big cubicles where we cannot have the machine on the opposite side. If you can't have the machine on the opposite side, that's the best thing to do. But even if you're having machine on the same side, make sure it's within your line of sight. So as you can see, I've taken a picture from where I was standing, and this is within the line of sight. Now we're going to talk about your position and the patient's position. So it's quite important that when you're cannulating, either lie down the patient and get the arm to rest on the bed or the trolley, so that the arm is immobile. So the patient is not holding the arm in a position. So if it's lying on in the trolley or on the bed, it's quite immobile. So the patient is not using their muscles to keep that arm immobile. The other thing that I would suggest is that either you sit down yourself, which is much better, or if there's no place to sit down, get the bed out. What you want is to immobilize your shoulder and immobilize your elbow, so that you can only do fine movements with your hand, and there are no movements at the big joints, because you can only do fine movements on the smaller joints. And if you're moving your big joints, then you're doing quite coarse movements. So that's quite important. So immobilize your shoulder and your elbow at 90 degrees. So either sit down or get the patient up or the bed up. Another very important thing that I'm quite anal about it is how you hold the probe. So as you can see in this picture, I'm holding the probe from the base, and I'm only holding it from with 2 fingers, and the rest of the fingers are on the patient. So this is quite vital to your success rate. If you're holding your probe from higher up, you're going to push the probe on the patient. And as soon as you put in the needle, you're going to get a little bit more tense. So the pressure on the patient and the skin and the veins increases. And this leads to collapse of veins. So it's quite important that you with your fingers, hold the probe and only feather stroke the probe on the skin, so that you don't put any pressure on the skin or the veins. And this is quite important although I know we have difficult veins because people have got difficult IV access in them because of fatty tissue or difficult veins. But somebody who is quite dehydrated, is quite hypovolemic, and if you're using ultrasound for that kind of cannulation, an even small amount of pressure will just collapse the veins. And that's why some people scan the arm and they can't see any veins, because they're putting too much pressure. So all of the superficial veins are already collapsed because of that pressure. So just be mindful, hold the probe, fingers on the patient, and feather stroke the probe on the patient's skin. Any questions so far? If not, I can take the questions at the end as well.
I'll keep an eye out for anything in the chat, but not so far.
Okay. Another important bit, let's go back. Yeah. Another important bit is something called, this is something that I've taken from, is probe drift, or what I call continental drift. So if you're not anchoring your probe with your fingers, then as soon as you turn away to get the cannula or you're looking at the screen, your arm will drift. And this is what happens, is that your arm will slide off of the curved arm, and it will gradually move laterally. As you can see in this machine, so in this view that you've got, centrally you've got brachial artery, but as you can see that the hand is drifting laterally. So it's quite important to anchor your probe with your fingers so that there is no drift, because you would not be looking at the probe or the hand, you will be looking at your machine. Okay, so we talked about this. Okay, so yeah, we're going to talk about how we're going to scan. So what I tend to do is I tend to clean the whole arm with a cleaning solution, get the probe cover on, and then start at the ACF. What you want on the ACF is to visualize the brachial artery. And as you can see in this clip, on the medial side of it, this is the this is the cubital vein. And can you see how much pressure I'm putting on the probe as well? That the cubital vein is being pressed. This is wrong. This is something that I deliberately did just to show that if you put even a little bit of pressure, the veins collapse. On the medial side of it will be on top of the brachial artery will be the median cubital artery. On the lateral side of it will be the cephalic artery. Let's go back if we can show. So yeah, median cubital artery on top. Laterally, we'll have cephalic vein, and medial to it will be the basilic vein as you go into the arm. What I tend to do is scan over here, and then I scan downwards. And these are the veins that I usually cannulate. Okay, go back. So what is an ideal vein for us to cannulate with ultrasound? So initially, when you are using as a novice, I would say the ideal depth for a vein should be not less than 0.5 centimeters and not more than 2 centimeters. If it's less than 0.5 centimeters, you don't have enough room to use ultrasound or to visualize the needle for cannulation. You might have to go at a very, very shallow angle and probably a little bit proximal. That's what, when you've got more experience, you can cannulate veins that are shallower than 0.5 centimeters. But if you're as a novice using it, 0.5 to 2 centimeter is your ideal depth. And the size should be about 1.5 millimeters at least. Because anything less than that, you might struggle to get the cannula. And even if you do get the cannula, it might not work very properly, or it might cause pain to the patient. And there's more risk of thrombophlebitis if you completely occlude the lumen with the cannula. So remember the orientation as well. The probe pointer should always be pointing towards where it's pointing on the screen. So if you have the screen, talk about this. So on my screen, the pointer is on this side, and the probe is also pointing towards this side, the pointer over here. So remember just to match the screen. It could be, if you're coming from the neck end, you might have to go on a different side of the patient. So people talk about the probe pointer always on the patient's right side, but that's not correct. It should just match the screen. However you're oriented, just make sure your probe pointer is pointing where it's pointing on the screen in your line of sight. So let's talk about a few probe movements and the nomenclature that we have for that. So this is something I've taken from Johnny Wilkinson. So there are a few probe movements. For ultrasound guided cannulation, we're going to use something called pressure. So we need to press on the veins and the arteries to see which one is the artery and which one is the vein. So anything that collapses with a little bit of pressure is most likely going to be a vein. And the arteries, we have to recognize them by anatomy, but also by whenever we press on them, they will show pulsations rather than collapsing. If you move the probe in its y-axis, that's called sliding. This can be used for inline cannulation, which I'm not going to talk so much about because I usually use out of plane, not in plane cannulation. We're not going to talk about rotation much or rocking. What we're going to talk about is sweeping. So this is the movement that you're going to do. So movement along. So yeah, sliding is movement along x-axis. This is wrong. And sweeping is movement along y-axis. So this is what you're moving forward or backwards. So that's sweeping. Okay, so this is the movement that we're going to do for our cannulation. So started at ACF. And as you can see, of trying to sweep up and down and see how the veins are either converging or diverging. So it's very important to recognize the anatomy of your veins as well. But also, this is something that I've taken a clip of. Can you see how the veins can be moving diagonally, but they're not always vertical. They can move diagonally as well. This is very important. If you scan up and down and your vein moves from one side of the screen to another, it means that the vein is diagonal to the probe. What you want to do is you want to find that ideal vein, but also make sure that your probe is perpendicular to that vein. So if the vein is like this and your probe is moving like this, so it's going to be diagonal. So it's going to move across the screen. What you want is minimal movement of the vein on the screen. Is you want to make sure that it's perpendicular. So you move up and down, and you can cannulate in one direction. So you don't have to cannulate diagonally. You can just cannulate vertically. This is quite important. So make sure you scan up and down, find the axis of the vein, and put your probe perpendicular to it so that the vein doesn't move on the screen. It stays in the middle of the screen, and that's where how you're going to cannulate. We'll talk about a little bit about Doppler effect if you haven't heard about it. Wait. It's not playing. Anyways, so Doppler effect is change in wavelength of the ultrasound wave or any kind of wave as the emitting source moves in forwards and backwards. So what Doppler does is, in simple words, it shows in the color Doppler that we use for ultrasound cannulation, it shows us flow. So you might have organs or you might have an abscess within the arm. This would not show flow, but veins and arteries would show flow because there is blood moving in them. So Dopplers are only good to show flow and to recognize that this is a vascular structure. They don't tell us which one is an artery or which one is a vein, especially color Doppler. You can use pulse wave Doppler to look at waveforms, but also the best thing is to know the anatomy. Press on the veins and arteries. Veins should be oblong shaped, and they can be compressible with a little bit of pressure, and arteries are more of a rounded shape, and they don't compress that easily. Something that I want to highlight is edge artifact in ultrasound. So what happens is that with ultrasound waves, basically the ultrasound probe is an emitter, but also an absorber as well. It basically receives all the waves emitted from tissues. So in a circular object or in a circular target, most of the waves will be transmitted from the top bit backwards to the probes, but from the side walls, the waves will not be transmitted back. What happens is the wave will fall over here and then will go in different directions, but not back to the probe. Hence, the side walls of any vessel will not be very clear. Only the top and bottom walls will be very, very clear. And that's why you want to make sure that your probe alignment is perpendicular to the vessel so that you're not coming from the side, because you might either go through and not recognize it, or you might not go through at all into the vein. Again, just another example of how veins go diagonally in different directions and how to make sure that you keep your veins centrally within the screen. So let's talk about technique. So we've got two techniques, which is in plane and out of plane. So this is an in plane technique because the axis of the vein, the axis of the probe are all in line, and you're coming in line along the axis of the vein into the vessel. This technique is favored by some people, but I think out of plane is much better if you want to cannulate superficially, but also if you want to cannulate any smaller target as well. The out of plane is because you're perpendicular to the axis of the vessel, and you're also coming in line with the axis of the vessel. So, but you're coming perpendicular to the probe. And I will show you how it looks like and what sort of movements we need to do in order for successful cannulation. Just another artifact for ultrasound that we're going to use is reverberation artifact. But also this is to highlight that if your probe is perpendicular to an object or a vessel, most of the ultrasound beams will go back to the probe. This will make it very clear and very nice. But if you are perpendicular to the object, then some of your veins will go off and will not come back to the, if you're not perpendicular, if you're at an angle, then some of the veins will go reflect in different directions, will not come back to the probe. So if you are at an angle to the vessel like this, so your waves will go forward, will not come back to the probe, so that wall of the vessel will not be very clear. So it's very, very important that you're always perpendicular to the skin and perpendicular to the vessel. Reverberation is quite important because when you are, consider this as a cannula, you will get some reverberation artifact as well. And this highlights that you are looking at the shaft, because the edge of the cannula, which has got the bevel, only has got one wall. As soon as you move from the edge to the shaft, which has got two walls, you'll start seeing reverberation artifact. So this is a bit of a gift about how not to cannulate. So people use different algorithms. They use the Pythagoras theorem about going 1 centimeter behind the probe and then targeting the vessel. And once you are in the line of sight, then you will probably be at the vessel. As you can see, the whole of this length of the needle, we don't know where it is. So from my technique, what I tend to tell people is that you need to go next to the probe so that you can visualize the edge of the needle, so the leading edge of the needle, and then you can direct that into the vessel. If you're going 1 or 2 centimeters behind the probe, you don't know what structures have you passed through or where your needle is until it reaches the line of sight, which is something that I don't recommend. I think we should be visualizing the tip of your needle all the time as you're going into the vessel. This is the safest way to cannulate somebody. Because you might have some nerves that you don't see, and you might go through a nerve, cause severe pain or damage to the patient. So I didn't know how to, because I didn't have somebody taking a video of me while I was cannulating. So this is a kind of a picture that tells you how to cannulate and how to move your probe. So essentially you're using an out of plane approach, and again, you are introducing your needle into the skin, and this is a needle tip. However, it is far away from your vessel. What you need to do now, once you see your needle tip, you need to stop moving your needle and sweep your probe forwards. As you can see from here, the probe moved forward, and you don't see the tip of the needle now in this step 2. In step 3, you need to keep your probe stationary and then advance the needle forwards. And As you can see now, you're closer to the vessel, deeper into the tissue. Again, once again, now you're going to keep your needle stationary and move the probe forward. You don't see the tip of the needle. And once again, you're going to then stop the probe, advance the needle, and by repeating this movement, you're going to go into the vessel. And this is a very, very vital point where a lot of people fail because once they see the flashback, they just remove the probe and then advance the needle. Take out the needle and advance the cannula. It's very vital that once you're in the vessel, you don't look at the flashback, don't look at the probe, don't look at the arm. Just keep advancing this further into the vessel until you're in the vessel. Okay, and then take out the needle. It's very vital that you do that because otherwise the chances of the cannula tissuing are very high. Okay, so this is a phantom that I was using, and I'm trying to simulate the movements of out of plane approach. So as you can see, as I see the tip of the needle over here, I stop and I move the probe forwards, and then stop, move the probe forwards, and you can see the needle is moving deeper and deeper into the tissue. Okay, so this is the kind of movement that you're doing. So, needle probe, and keep following it. I'm just going to quickly show you out the in-plane approach as well and how the needle looks like. So this is the in-plane approach. As you can see, the needle is coming from this side. And you can see that's reaching the target. There are some disadvantages in both, but I'm just going to talk about the in-plane approach and how it can be slightly disadvantageous, especially for superficial vessels and smaller vessels. One of the things that I want to highlight over here is that make sure that you've got less acute angle when you're introducing a needle. So as you can see, these are the ultrasound waves, and you can see the most reflection is when the needle is horizontal. As you go at a higher and higher angle, more and more waves will move away from the ultrasound probe and you won't see the needle. It's very important to have a less acute angle, a shallow angle when you're going into the tissue. So this is quite important, especially for in-plane approach. So an ultrasound probe will have the main beam within the center, but it will have side lobes as well. So it will have some ultrasound waves that will come off straight, but then deviate slightly and create some side lobes. With the in-plane approach, that's the problem is if you are in the middle, that's very good, but sometimes you can not be in the main beam and in the side lobe. But if you've got a very reflective surface like a cannula in the side lobe, it will appear as it is over here in the main beam. And that's a problem because you might not be in the vessel, which might be here. Your cannula would be here, but it would appear as the cannula is within the vessel. And this is one of the main problems with in-plane approach is because if your target is, if you're using a peripheral vein, peripheral veins are quite small, so they will appear in the main beam. But if your cannula is in front or at the back of the vessel, it can still appear as it is in the vessel. If you cannulate a CVP and internal jugular vein, those are fine. You can use an in-plane approach, but with peripheral IBXs, I would not suggest that use in-plane approach. Just because of this, you can be fooled by the ultrasound machine. Okay, let's talk about the cannula size. This is a very, very important topic. As you're cannulating anything below 0.5 centimeters to about 2 centimeters, remember to use a green cannula. Most of the green cannulas that we have they're for about 3.2 to 3.5 centimeters. Because if you use the Pythagoras theorem, you can see that if you're going diagonally into the tissue, and your target is about 2 centimeters deep. So you're going to use about 2.5 centimeters of the length of the cannula within that tissue. And you're going to only have 1 to 0.7 centimeters of that cannula within the vessel. Roughly, it's stated in some studies that if you have 1 centimeter of the cannula within the vessel, then the cannula doesn't issue. And this is vital because you need 1 centimeter, because if your arm moves, you need to allow for that movement. So if it's about 0.5 centimeters or 0.2 centimeters, if your arm moves, it will come out because these are deeper cannulas. So you need to have at least 1 centimeter within that vessel. So always use, especially when you're starting out, always use a green cannula. The green cannula can go in most of the veins of the arm. So always use a green cannula. Make sure that you get the most of the length within the vein itself. And sometimes in order to confirm the length of the cannula within the vessel, you can use an in-plane approach and have a look at how much cannula was within the vessel. Once you become more expert, if you're choosing a target which is more than 2 centimeters deep, then use longer cannulas. There are special cannulas which are about 6 centimeters, 7 centimeters long. Use them. If you are really struggling and you don't have any other option, then you can use your Wygon arterial cannulas as well. But remember that these are only temporary. Don't use that for longer term. Just use it enough to get a good IV access, because people might be confused by the Wygon cannulas because they are red colored, and they might just think that this is an arterial line whilst it's within the vein. So just to avoid that confusion, don't use it for longer term. Just use it as a temporary measure. And I think that's about it. I would say your guys are all here. You're joining the focus revolution. Please ask me any questions if you have. And thank you.
Thanks, Salman. That was great. And did you want to talk about more now, or should we do a few questions?
Let's do a few questions first, and I think we can talk about more afterwards.
Perfect. Okay. So I had a question about I think some of us might have heard, and you've definitely heard this, about the safety alerts that's going on regarding ultrasound gel and association with I can't tell the name of the organism, but there is some bacteria. Yeah, so there is a kind of bacterial organism that was grown in the ultrasound. There was a safety alert that's going around, kind of asking us to use anything sterile and not from the bottle for anything invasive. Would you consider peripheral IV cannulation?
Yeah, anything that's going into the skin is invasive. So I would suggest use a sterile jelly. If you don't have it, you can use Optilube. If you don't have Optilube, you can just use the pink spray, the chloroprep spray. That can be used. If you don't have anything else, and if you clean the skin, you can use sterile water as well, or sterile saline. But just remember that saline, I used to use it quite a lot, but saline evaporates very quickly and it comes off the skin very quickly as well. So jelly, if you're taking a longer time, then you might need somebody else to squirt the saline. But jelly is quite recommended, and you can use Optilube as well. It comes in sachets, so it's sterile enough.
Yeah, perfect. I think I've gone away from using the bottles only because I've recently, like whenever I go hunt for the ultrasound machine, the bottle's on the floor, the probe's also on the floor. There's some old blood on the probe. So I think it becomes a bit of a kind of worry that, you're introducing infection. So yeah, but we find Optilube everywhere and quite easy to use it.
Yeah.
But yeah.
Yeah, what I tend to do, sorry to cut you, I always clean the probe before I use it. So make sure the probe is clean. Even it looks clean, still use a cleaner wipe and clean it. And then use a probe cover or Tegaderm, something to cover it so that it doesn't get in contact with the skin. And yeah, and then go ahead. Use sterile jelly as well.
Sounds good. Do you use Tegaderm for all your peripheral IV cannulations?
In our trust, so we decided that Tegaderm is good enough. Although I know it's porous and it's got 0.5 micron pores, uh, but for all purposes, we thought this is good enough. So, as a trust policy, we are using Tegaderm rather than probe coverage. But just go with your trust policy. I would say that.
Great. There's no questions in the chat. But just like a comment, I had this, at least this is what I felt when I initially started cannulating with ultrasound and I was struggling. As in when I got better, I found that the skill that you kind of actually achieve by doing lots of IV cannulation, the needling technique, the hand-eye coordination, and once you become quite good at it, you barely look at the hand or the arm of the patient. You're constantly looking at the machine, and there's always somebody next to you who, as soon as you get flashback, keeps saying you're in. But I think just to hammer through what you said earlier is you might be getting flashback, but you might struggle to thread in. So making sure you're looking at the tip all through and going into the vessel is one good tip. But also this skill actually builds up to other things that you can use focus for, which is slightly advanced, but it is the basic basement or the foundation for it to help with needling technique for regional anesthesia, your arc lines, central lines, even doing ultrasound guided, like, chest drains or maybe doing ascitic drains and things like that. So I found this ultrasound IV cannulation is something that we start off very early, but it's kind of the most important skill, and you can build a lot over it.
Yeah. I think it seems like, when I was trained in Pakistan, so as a house officer, you always get to do an appendicectomy. Appendicectomy was considered like it's a simple procedure. It's not a simple procedure, but it's so commonly done that as a house officer, you get to do one appendicectomy on your own. But yeah, so ultrasound, I consider IVX as appendicectomy for surgery. It's such a common procedure, but it requires its own expertise. So you can't just be doing it. Yeah, it requires a bit of finesse, a bit of experience, a bit of understanding of the pitfalls. Let me see. There's a question. You mentioned to use a more shallow angle to avoid reflection. How can angle the probe to do this? I didn't get the question. Is it that you're saying for in-plane technique that you should use a shallow angle? So you don't need to angle your probe. So the angle, as I said, the probe should always be perpendicular to the skin. What you need to do is you need to put your target at a far end. So suppose if you're coming from the left hand of the screen, this side, so your target should be on this side. So then you can have a shallow angle. So you're going to go like this. Suppose if your target is over here, then you're going to go at an acute angle, and you're going to go like this. So you don't have to change the probe. The probe should always be perpendicular to the skin. There should be no angling of the probe, but you can just change the position of your target. So if you're coming, if the target is deep enough, so you can have it on the opposite side of the screen and then use a shallow angle to come down. If somebody else was writing a question and then they deleted it. Any other questions, guys? You can shout out if you want.
Yeah, you can feel free to unmute and just ask the question. And you mentioned about the tracking the needle step by step, and I think some people like Jalen, Avila, and some core ultrasound people call it like the sequential needle tracking. Is that what you normally do for all out of plane approaches?
Yeah, so for all out of plane approach, it has to be needle tracking. And as I said, for me, I make sure that my needle is very next to the probe. So I don't go 1 centimeters or 1.5 centimeters behind the probe. I know some people use that, but for me, it's vital that I see the tip of the needle all the way through where it's going through the tissue and then into the vessel. So just needle cracking. You can call it whatever. I used to call it, sometimes you can say Tom and Jerry. So one is running off at the other. But yeah, you just need to make sure that you follow your needle. You follow your probe with the needle and just keep doing that. Keep moving forwards deeper into the vessel.
Great. Just, I'm not sure if you can see, can anybody see my video screen? Basically, I'm not sharing screen, but I'm just changing my video to...
You got the blur on.
Oh, I got the blur on. So let me do none.
There we go.
Are you able to see some kind of a slide?
Yep.
Yeah, so this is from I don't know when I made this, but I've taken this from Core Ultrasound. So let's see. Can you see it still on the screen?
Yep.
Yeah, perfect. So this is what I thought I'll just share, is the needle tip tracking. So that's your probe, that's your needle, and this is your vein, and you've got that just coming there. And you can see, I liked what you said earlier. You always start off very close to the probe, and this is exactly what I do as well. So you know exactly where your needle tip is, rather than going a bit on maths, and we're not good at maths, and that's why you're doing medicine. But this is basically trying to look at all the structures you go through with the tip. And as soon as you see the tip, you basically stop. You move the probe so that you look at the rest of the kind of the vein and keep tracking. And at some point, you're going to indent the vein and kind of go into it. And then once you're in, you can obviously do the same thing. I guess I've got somebody doing it as well. So this literally doing the same thing. And once you're in the vein, you can just flatten.
Yeah, I think another part is very important. If you can just play this video again. Yes, if you guys are cannulating something, so the vein will first get indented, and then suddenly once you go on through the vein, you will see the vein will then regain its oval or whatever.
Oh yes.
So just look for that. This is another sign that you're within the vessel. And you see that it's
gone back.
Yeah. Suddenly it regains its own shape. So that's a very good tip as well.
So just it gets indented, and then you pop through it. Is that what you're saying? Yeah, and then you're back to. Yeah, and then now you just see the white tip in the middle, so you know you're completely in the middle of the vessel. Oh, that was perfect.
I think we've got 5 minutes. So I'm just going to use this forum for my own purposes. Group, which is looking at management of rib fractures.
Salman, sorry to, I think we just got cut off a bit in the start. If you don't mind starting again.
Oh, right. Yeah. So I'm part of a group which is looking at management of rib fractures nationally. So it's a national service evaluation, which is looking at recruiting hospitals, which will then recruit some patients. Basically, we're looking at data and seeing how different hospitals manage rib fractures differently, and what is the overall mortality and morbidity associated with it. It's called MORPH, so Management of Rib Fractures UK. There is a Twitter page, and you can also just DM me on Twitter, or the email is morphuk2024@gmail.com. But again, if you want to get involved, we're looking for sites. We've got about 65 sites which have expressed interest, but we're looking for more sites, thinking of more than 100 sites if we can. It would be great if you guys want to get involved. So those who will get involved, all the PIs and collaborators will be named as authors on the publication. So you can search yourself. Once it gets published, you can search yourself on PubMed as well. So it will be under your name. So yeah, do get involved. It's a good way of getting involved with research, getting a publication. And if you're looking for applying for maybe a different post later on or interview, that gives you some points for that as well. Yeah, great. Thank you. Gokul has just put in the link for the Morph UK Twitter page. Yeah, either DM there or DM me, and I can get you involved with that. That would be great.
And the email is morph.uk2024@gmail.com, correct?
Yeah.
Like I'll just share that. Yeah, it's on the Twitter page as well. I just saw.
Well, there you go.
Great, guys. That was I think it was a really useful and good session. And people think that we are quite comfortable doing IV cannulation, but when there is a sick patient who actually needs a quick and it's a difficult access, that's where your skills really get tested. And actually, the ones who are really comfortable and are systematic are actually successful, and you can see the difference. So hopefully, we all reach that point where we feel comfortable doing it even in a very sick patient who's moving around, who's quite agitated, but that IV cannulation is going to change management quite quickly. Hopefully that was useful. If nobody has any burning questions about Morph or UK or about the session itself, then we might call it there. I can't see any questions on the chat. There was something about the email. Oh, yeah, this email is shared as well. Thank you. Thank you for joining us. We will be back next month with another session. Till I pester somebody to come on and teach something related to core ultrasound skills, but it'll be quite interesting. And we think it might be related to something that we use regularly, and something that we use regularly in terms of, we just say fast scan. Everything is a fast scan, but we'll talk about what exactly fast is and what exactly is an abdomen scan in the next month's session. So thanks, and see you next month.
Thank you. Thank you, Gokul. Thank you, everyone.
Thanks a lot. Recording.